So good morning to everyone. Welcome to Obergurgl. Great to see some faces I know, and great to get to see new faces. Transition is a topic that has started over the last few years, especially in the surgical areas. Transition is much longer in the internal medicine areas, in transplant sometimes, but it's slowly coming over to other diseases. And I was asked to talk about anorectal malformations. There are certain facts we know for sure about anorectal malformations, and that's that all of those patients are going to need some kind of transition. And if you don't think so, then you're doing something wrong. And that many of the principles already apply. So we already had an excellent presentation. Oh, this was the right. Excellent presentation, and we touched many of the topics. So some of them are kind of sound similar, but I wanted to keep this more broad and applicable to different other specialties, because not everybody is doing pediatric surgery. Then I was asked to do a presentation about the pediatric surgeon's view. I don't know how everybody thinks, but this is my view, so I hope we agree on some of the points. So what is transition, and where did it start? In the last 5 pediatric colorectal conferences I was at, transition was hardly a topic, or if it was only talked about peripherically. It was never like a main thing or a main lecture, and no words were lost on transition. So now, either due to necessity or because we surgeons have a wishful thinking about it, or because it's a trend, I don't know why, but it's coming more and more, and we're being confronted more with this topic. So there are a lot of new challenges we get to see because of that. So I said some specialties like heart transplantation generally, or heart disease, or some metabolic problems, they already are much more advanced than we are in surgery, and especially in specialty pediatric surgery like anorectal malformations. So in the past, our transition was telling the 18-year-old boy or girl, so now it's time to look for an adult provider, thank you very much. And that's not the way it works, or that's not how it should work. An informal questionnaire asked who even needs transition. Is this something we should apply for every child? We all know we're in constant development. We're not the same at 5, we're not the same at 10, we're not the same at 50, and we're not the same at 40 or 60. So is there something that should be a system in place that should go for forever, or is this a specific topic that should only interest people with chronic diseases? And we see there is some disagreement about it. About half of the doctors think we only need transition for children with illnesses, be it chronic or any type of acute illness that falls into the category needing a transition, meaning change of age. So in an informal questionnaire, 5% of adults with anorectal malformations thought they got the appropriate transition and were happy with how they were transitioned to adult services. So if we think 10% is about the global risk somebody has of having an acute appendicitis. So we're saying patients with anorectal malformations have twice the risk of having an acute appendicitis, if it wasn't taken out before, which I hope they didn't, than having a good transition. And if you think about that, it doesn't make sense at all, right? So we are facing challenges that we can only tackle if we try to break it up into the different areas that produce resistance to those challenges. And those are some that have already been taught here. So transition, we know, is the adolescence of care. Nobody wants to talk about it, or nobody wants to deal with it because it's difficult. There is no one straight answer, and it just has too many components and too many out for surgeons. Surgeons are usually quite pragmatic. I go there, I do this, and then I have a solution. And many times transition is more about adaptation, about getting people to work together, and that can be very challenging. So in previous presentations, for example, I saw that like 45% of people that had a transition lack an expert that knows about, meaning I send him to, a child has an anorectal malformation, and send him to a surgeon, and this surgeon, an adult surgeon, this surgeon has, in many cases, never even seen a child with an anorectal malformation. So how is he supposed to know what the problems are or where to start. So the computer froze, 1 minute. Okay. And from previous data, we also know about a third of the patients are discharged from care before they're even 10 years old. So as pediatric surgeons, we all know that that this is that many children come to us like still in their 20s, but usually, unfortunately, there are also many cases where people received some type of surgery and were released, and there is the and they are gone. And it happens in we call it sometimes loss to follow-up. Many times it's not the patient, because of some study we have made in Honduras, we've seen follow-up is not as bad as we think if you give them the means to have a follow-up. So if they can do it in Honduras, I'm sure we should be able to do it in Europe. So what is the first challenge I want to do, or to present? It's the definition. We need to speak the same language when we're talking about the disease. Many patients don't even know their correct diagnosis, and this time I'm referring to anorectal malformations. So how is he going to explain his next care provider what his problems is or what his diagnosis was? So if you go and say, I have some illness with my heart, or I have some illness with my butt, you're like, well, what illness? What's your problem? And that's where we first need to work. Many people in the anorectal world have, maybe Greg, he has done a lot of work. He's created a patients association. He's in Australia, and he's a patient of having this problem. So he made this, he asked 841 adults with colorectal malformations what was their original diagnosis. And 77% said they had an imperforate diagnosis. Now there was, in the years ago, the Crick-and-Bay classification, where we know that not all imperforate anos is the same. We can have a very mild form and we can have a very severe. But if you go with this, you see most patients don't even exactly understand what they have. So if we don't agree on the definitions, how can we optimize and equalize care? So the first thing is to start with this. And in anorectal malformations, for 5 hours of surgery, you need at least 95 hours of non-surgical care, it said. So if you're not willing to do this boring work as a surgeon, then I think either don't do it or try to put up a team that can do it. APNs may work, social workers, anybody that you can take in your hospital and get them interested in this topic. If you don't do, and we know that if we don't have correct clinical follow-up in anorectal malformations, you end up with 95 hours of surgeries and very unhappy patients that look like this. So there is nothing worse than following different lines, going to the hospital, being always seen by a different doctor, having a different information, and that leads to confusion, and it's not going to lead the results we want. So we need to, how do we tackle it? We tackle it with education. Without education and awareness, we're not going to see any progress, neither in colorectal surgery or in any other type of specialty. So if we see this curves, these are the amount of bills that the Congress in the US has covered or talked about. And then the curve below, the black one, I don't know if you can read it, but it says articles in PubMed with awareness data. So sometimes we get bombarded with those, today is awareness for whatever, today is the awareness for whatever. But if we don't do it, and we don't do it at all in anorectal malformations, people don't know it exists. And we see that they have a good results. For example, see how many millions breast cancer brings in, because everybody's wearing a pink ribbon. We have Movember, and everybody's having, and we often think those are laughable, but they seem to work. As we can see, things that have an awareness, they are most covered in Congress and are most published about. So we need to probably work on that. We need to educate patients. We need to see that not all patients have the same problems. In anorectal malformations, of course 89% have some type of bowel problem, but we can see they have many other problems, and there is where other specialties come in. So the problems are you can see that they are very varied, and you can have very mild problems and very acute problems. So we need to somehow be able to distribute those resources and bring them all together to deal with all of this, because no one doctor can take care of all of these problems in his time. And we shouldn't forget that there is one of the biggest weaknesses in any transitional program is the psychological part. Many patients with anorectal malformations are going to have psychological issues, and that comes from just being different. They may not even have that many problems, but they may look a little different or behave a little different, and that needs to be addressed, otherwise we end up with some problems we're going to be before. So what's the solution for the first part, for definitions? It's education and awareness. So I don't know if some of you know Gary Larson. He makes this scientific cartoons, and in this one he's like, Mr. Obergurgl, may I be excused, my brain is full. We always talk about education and we think not again and not again. In this case, education is, I want it more broadly. I don't want it only for doctors, but also to be transmitted to the patients and the future caregivers. What's the second challenge? Data. And we already see that there are some good solutions coming to here, but many times when I see a new patient, where the patient comes with something like this and says, this is my medical records, so you can see what I have. And don't you love it when that happens to you? And then you ask them, what was the last x-ray? And they start going through this whole pile for hours and picking all laboratories and showing it to you. Things that may not even be relevant at the moment, they think it's relevant, but they keep every single thing. So if we cannot take all the noise out from it and get to the essential parts, we may not be able to squeeze our patients. We have 30 patients waiting outside. How are we going to squeeze that with all this information? It doesn't make sense. So all this noise only confuses us and makes care worse. So being too careful about record keeping can actually be counterproductive in cases like this. So how do we find the jewels in that information that we need to find? We know there's 2014 there were 1,100 different types of electronic health records. So you could choose from 1,100 types of different software to save your records. And so a little clinic here has this type, the other clinic there, the hospital uses something different. There in the US there are some bigger ones like Epic or some SAP programs, but generally there are 1,100. And each one uses different types of databases and different of data management, which means you cannot combine those. Have you ever tried to transfer your picture library from, I don't know, Windows to Mac and end up having everything double and triple and being a big mess? So it's something similar. You can very difficultly combine databases. So what you need to do is to agree on a standard. It doesn't need even be the same software, but it should be the same variable names, it should be the same type of software, either SQL, NoSQL, and these kind of things that are going to allow different databases to work together. So if we look at evolution, we are probably here. We're working with pen and papers. Administrators would like us to be here so we can code everything we do so they can bill later. So we spend a lot of time on the computer putting in codes so the administrator can bill it and not really putting in the information we need. And probably we should be here. Like, why don't make, and we already have the technology for that, why don't make information acquirement a passive thing? We have voice recognition, we have programs, and then we can pre-program and have the software select the parts that are important for us. So that's probably what we need to push for in the future and get out of the whole information mess we have on the database. Because we have enough data, we just have not been able to put it in an order that it can work with it. So the solution for that second challenge is trying to work on a unity. Get together, get a single data collection language, not even the same software, but language, so that we can combine data and work together. The third is communication. We always talk about communication. We all think we're great communicators because we come to Obergurgl and laugh a lot and communicate. But communication is probably in the hospital one of the biggest challenges, and when talking to different specialties it is. So you write a little, the patient comes to you and you write you want to send him for another services and you write a one-liner like, if I want to send him for urology, I write, anorectal malformation needs urological evaluation. The urologist sees this and doesn't even know where to start because it's a very broad thing. It could be that the patient has problems urinating, it could be that the patient has pain, it could be, I don't know. And he doesn't really know the history and needs to start talking about it. So there's nothing like personal contact. So you need to talk to the people. No matter how many written information you have, when you get him to a new provider, you need to call this person or meet them in person and take care of it and talk to it. And we're going to see something else about communication. But many times the best way to communicate is share patient time together, which means having a clinic where the different specialties come in, and a lot of the communication happens actually outside of the patient unit. But having the same clinical day, the same appointments helps a lot, because sometimes the information needs to be in the little bits of information, in those things that you say but maybe don't write it because of, I don't know, either legal, you're afraid of legal things, or because you don't deem it important at that point, but when you're saying to your colleague, maybe that's the piece that your colleague is missing. So if you're planning to have an adult surgeon taking care of your patient, have him be part of the clinic and management early in the process. Don't get him when the patient is already 18 years old. Get him early in the process, even invite him maybe for a surgery, and slowly start transition. And that's why programs where gynecology is invited and urology to the surgery, even if they may not be active operating, they need to know what's going on. So what's the solution? It's to work together or try to talk in person, either through the phone. Some here may not even know what this device is. It's a phone. And for the people that know, they probably already have had the experience that not talking to the people brings confusion and problems. The fourth thing is politics. And politics is very specific to every different hospital and every different country. We have different health systems and we have different needs. But you need to address it. You cannot go be a lonely rider or be Lucky Luke and think you can solve it on your own. So you cannot build a center where you have transitional care and multidisciplinary care without involving the politicians in your hospital, and even more the politicians in your city and the politicians in your state. Because as we saw, we're going to need money, and money doesn't come from service alone, especially for these specialties that don't bring a lot of money. So we need to talk to people, we need to talk to politics, we need to ask them to create centralized databases where we can collect national data, where we can agree on different things. And as we know, we're humans, and talking to people in person and being with them and trying to get them convinced is more important than presenting the facts. If I tell you about a little girl outside here that's crying and her mother died yesterday and the dog is lost in the snow and she's hungry, I'm sure 50 of you are going to run out and try to feed the child and bring her bread or something. If I tell you every minute there are like 5 children dying in Syria, well, it's not my problem. So people need to feel it, and to feel it you need to talk to them and inspire them. And our fifth and last challenge is centralization. Centralization means rare diseases need to be taken care in a place that can acquire enough volume of that. Otherwise, it's not financially feasible. We need nurses, we need maybe other specialties, other doctors. So if we don't centralize, how do we get the numbers together? We need to have all the numbers, enough numbers that the system can run and be financially efficient. It wouldn't be good to hire an APN for bowel management if you're going to see 2 patients a month. That would be like unacceptable and very expensive. So we need to start working, and that's very hard, to let our egos go and try to define places where we already have some of the basics to start centralizing and start working on them. So specialization is very important. We know we have like 30 medical publications every minute, and not for anorectal malformations, luckily, but for all of medicine. So we cannot work it all. So to be able to be good on our topic, we need to define what our topic is going to be and then try to specialize into that. We're still a little far in pediatric surgery from that, but I guess the more knowledge becomes available, the more the necessity rises for that. And so what's the result? How do we address this challenge? We need to inspire people. We need to talk to them. We need to motivate them. We need to tell them stories about children who have the condition and make them aware. So politics and science, unfortunately, go very close together and need to be addressed that way. And that way we're going to be able to get the resources and we're going to be able to get the language. What happens if we don't do this? What are the consequences of a bad transition? We get a lot of psychological issues. First, we have depression, we have anxiety. Of course, a patient in our case that's not able to hold stool is going to have a lot of social interaction problems. We also are going to have poor clinical outcome. We know even the lightest forms of anorectal malformations, if we don't treat constipation, eventually they're going to end up within 10 years with a huge sigmoid and may not be able to be continent anymore for something that would have been very easy to treat initially and to prevent. There's the lost potential. If we don't do a good care from the beginning and the patient has already a low chance of being continent, we're going to not make him continent if we don't address it from the beginning. If we come in at 10 years and try to do something, it may already be too late. Damage is already done. And we know in studies from other, like especially from transplant, that there is a higher mortality. So if we don't have a good follow-up, even if you're the best surgeon in the world, you're going to have a higher mortality than the others. So this is a call. Let's tackle these challenges together. Let's try to create algorithms. Let's try to pick up on the work that already has been started and participate, be part of it, try to cooperate, and not always try to start from scratch. We always believe our clinic is the only one. Like today, I needed to come to Obergurgl to know there is a Kinderliga that's already doing transition in Austria, working in that hospital, and I didn't know. So we see communication is not easy, not even within the same hospital. And yeah, thank you for your attention, and discussion is open.